hemorrhages. I repeat again, like jaundice, photosensitization, hydroperitoneum, yeah, as well as hemorrhage. So they are important, particularly when you conduct a clinical examination. So jaundice or itchers, or sometimes we have also as a result of disturbances in the bile duct, we call it cholestasis. It's something to do with the discoloration of tissue and body fluid as a result of excess bile pigment, or as a result of overproduction of bilirubin, which is impaired excretion. Yeah? So I think in your general pathology, we have touched on this, where jaundice can be pre-hepatics, can be hepatics or post-hepatics. And many times, they might have a combination, whether combination of two or combination of all the three. Although in principle, like babesiosis, they're more towards of lysis or RBC when they're present of this protozoa within the red blood cell. Copper poisoning, I mentioned earlier, they can be hepatic at the early stage when there is a severe hepatic necrosis. But when the release of free copper in the blood circulation, that become a pre-hepatic because there will lysis of the RBC. But occasionally also, in cases of copper poisoning, there might be also some disturbances in the flow of the bile and can cause part or partial obstruction of the bile duct, and that will be more of a post-hepatics. So can be seen in both, all those three. Yeah? Well, in infectious kind of hepatitis, I think this adenovirus has very specific organ of the hepatocyte, leading to the formation of intranuclear accretion body, necrosis of the hepatocyte, as well as hemorrhages. Yeah? So more hepatic. And we have more common in cases of post-hepatic, where in cases of fasciolosis, yeah? Fasciola genetica, where that lead to accumulation or excessive adducts, in flux, liver flux, in the blood, in the gallbladder, as well as in the bile ducts. But of course, the fluke also during a process of migration, they cause damages of the hepatic parenchyma, meaning that they can cause necrosis also. So although they are common more pre-hepatic, that yet this fasciola can cause also leading to necrosis of the liver, leading to what we call it hepatic jaundice. Okay, so I think we are more familiar how this jaundice develop. Yeah? Then we look in terms of hepatic encephalopathy, and this is something that disturbances in the liver will cause what we call it nervous disturbances, particularly partly due to the hypoglycemia or failure of detoxification mechanism in the liberation of toxic breakdown produced of the liver parenchyma due to hepatic failure. So this is a more or indirect effect because of intoxication and leading to disturbances in the central nervous system. Very quite common also, particularly in this case, do a lot more in sheep, where leading to photosensitization, meaning that the skin of the animals, I mentioned it particularly in the sheep, become hyperkeratosis, necrosis, and present a lot of cast, yeah, as a result of exposure to the sunlight. So this partly because of hyperactivity of the skin due to the sunlight, particularly occur in herbivores as a result of acute or chronic liver diseases. Partly because the polyethylene is a papain-derived chlorophyll is normally excreted in the bile, but when the liver disease or there is necrosis of the liver, it is diverted back into the circulation and ultimately it accumulates in the skin. And will react with radiant energy, I think from the sunlight, for causing what we call it peroxidation of the cellular lipid and other cellular component, resulting inflammation and necrosis of the skin. So the presentation will be more on the photosensitization. Hydropericardium, quite number of hypericardum or edema. Yeah, edema hydropericardium means that presence of fluid in the abdominal cavity or in the peritoneal cavity. This is sometimes we call it also ascites, isn't it? So partly because of portal hypertension, when there's portal hypertension, that will lead to increase in blood pressure, might be maintain blood osmotic pressure, and maintain of tissue pressure and tissue osmotic pressure. That will lead to pouring of fluid from the blood vessel into the surrounding. The surrounding media, in this case, they might accumulate in the peritoneal cavity. So this is more mechanism of edema, yeah, edema, and that will lead to hydroperitoneum, fluid in the peritoneal cavities, and I will discuss in the earlier lectures, this hydroperitoneum could lead to death to the animals with various potential mechanisms. Sometimes also there are as a result of failure of the liver to anabolize amino acid and protein during hepatic diseases could lead to hyperproteinemia. Same thing also. When animals have hyperproteinemia, in this case, the blood pressure is maybe not affected, but blood osmotic pressure will drop. Again, when the blood osmotic pressure drops with the basically normal blood pressure, tissue osmotic pressure, and tissue pressure, so the fluid that been oozed out from the blood vessel might not able to return back to the circulation, and that lead to edema. Of course, the common edema will be in the lung because the spongy nature of the lung. But another common part, of course, is the peritoneum. That's why we have edema, or you call it hydroperitoneum or ascites. This very common. Yeah, you can be very common when you do your industrial training and in poultry farm. I think this is the most common changes or lesion you observe in some of the dead bird. Yeah? We can see that the abdominal cavity of the chicken is distended, and you can see from here even they are fluid-filled abdominal cavity. Okay, and when you open, this is how you can see apart from the fluid ooze out from those abdominal cavity, but you can see the liver there. This end there is very, what I call it, is very blunt. Yeah? The liver enlarged with blunt end, big reddening, swollen. This shows how actually the liver undergo inflammatory responses or hepatitis. Yeah? And this I will mention most of the time. This is a fibrin. You see the fibrin? More agenous material. And this fibrin actually is from fibrinogen. They escape from the blood vessel in the liver and leading to formation of this gelatinous material covering the surface of the liver. So we call it in this condition is the lesion fibrinous. It's a fibrin there. Fibrinous peri is outside the liver. Hepatitis, inflammation of the liver. Okay, you can say in this case there are more acute fibrinous prehepatitis. So where I mentioned just now, where actually Choy, Wayne Swain asked regarding the differentiated between acute, subacute, and chronic lesion. So in this case, this lesion actually is we call it as acute. Yeah, they can go acutely, meaning that the period of this lesion development may be within 2 to 3 days, something like that, less than 1 week. So in cases of acute, what you can see, of course, in this case, enlargement, and you can show those are the fibrin. The fibrin is very frank color of a fibrin. Yeah, they are very frank. So this occurrence will be acute. But in chronic form, maybe in addition to acute, sometimes it's associated also with hemorrhage. But in chronic form, because classification of acute, subacute, and chronic, you can classify based on gross nature. Like in this case, the more fibrin, they are more acute. Maybe some present a hemorrhage can be more acute. But in chronic form, you remember to see those of cirrhotic liver. Cirrhotic means there's a lot of fibrous tissue with island of proliferation or normal hepatocyte. That is chronic because they are present of a lot of fibrous tissue. Fibrous tissue is associated with chronic response, yeah, because they allow the liver, as a result of hepatic necrosis, then the area of this hepatic necrosis in the process of healing, they're replaced by fibrous tissue. And the rate of regeneration, because liver are able to regenerate with the rate of necrosis is slower, mean the necrosis is much more faster. That's why they form a lot of fibrous tissue surrounding the regenerate hepatocyte, and in severe condition, it becomes cirrhosis. Cirrhosis means there is a chronic lesion. Okay, so I'm talking about the gross appearance. Yeah? So anything in between, if you remember I showed you before, the fibrin is more cloudy, yeah, cloudy, not as frank as this. You see a liver, cirrhosis also is a hepatitis also. But the, what I call it, the fibrin, their color is much more opaque. Yeah, more opaque, more cloudy. That one, they are slightly beyond of the acute condition. Probably that condition, we call it as a subacute. Okay. To have a chronic lesion, it's much easier to differentiate with acute because chronic always have a lot of fibrous tissue, for example. But for acute form, they are always having more on the like fibrin, for example. Sometimes also is a hemorrhage, RBC. But beyond that, in between, if you think that they are not acute, even we discussed already, when you go to oral cavity with the tongue, the hemorrhage is more acute. The hemorrhage at the apical part of the tongue as a result of ulceration. But the whole thing is that the process of erosion and ulceration of those tongue, it need to form a certain period of time, probably more than 1 week. Okay, but they are not chronic because you didn't see any fibrous tissue there. So they are in between of acute and chronic. So we call it as a subacute. Actually, sometimes we might have also condition, we call it as pre-acute. Pre-acute, much more acute. Yeah? Okay, but that is not common. But that can occur, particularly in cases of myelinosis in the deer. Yeah, really pre-acute. But we seldom use the word of this pre-acute, and we might act more faster than acute. Yeah. So the common one, we classify lesion in terms of aging of the lesion, acute, subacute, and chronic. We can do that based on gross lesion, but probably when you do on the histological lesion, it's much more easier. Much more easier because on the histological lesion, it will be based on the inflammatory response. Okay, although be careful that inflammatory response is controlled by type of agent. For example, if the viruses, most of the time they have a lymphoid cell, a lymphocyte. When you have a bacteria, normally it's a neutrophils. Parasite is eosinophil. But many occasions, those in addition to presence of fibrin, in addition to presence of hemorrhage, in acute form also normally the cell that involved is neutrophils. The neutrophils. But in chronic form, okay, in chronic form, but don't confuse with the example that I give to you in cases of myelinosis, where you can see the lot of a dead neutrophil there, but the lesion there is not only the neutrophil, but those lesions, the tissue is covered by fibroblasts. It's a capsule. Abscess is covered by capsule, and the capsule comprised of fibroblasts. So that one is a chronic, because of the fibroblast covering the capsule of an abscess. So they are chronics. So chronic usually associated with the cell I mentioned today is more on the fibroblasts as well as chronic inflammatory responses such as macrophage, for example. You remember when you see case of Mycobacterium paratuberculosis, you got a lot of macrophage. In addition to that, we see also what you call it giant cell. So that justify that lesion actually is a chronic. When Yuen, you have any more to ask? Joy, are you here? Sorry, is Joy when Yuen is here online, please? Are you clear? Or you know, yeah, or anybody can like to ask regarding this to differentiate of the acute, subacute, and chronic lesion. Ada soal, ada tanya tak? Yes, class. Are you okay?
No question. Very clear.
Very clear. Yeah? You're clear. Yeah? I think I have received a question email from Yuen. So if Yuen have any more question, please ask. You are clear? Thank you very much. So they are going to differentiate. Meaning that when you do histology, much easier, particularly in the inflammatory cell. But in addition to that, because inflammation, we have acute, subacute, and chronic inflammation, and that is controlled by the type of the inflammatory cell. But again, when you look at tissue response to injury, normally the chronic will involve with fibrosis, sometimes also may be involved with proliferation of cell. Proliferation also usually associated with chronic because for the cell to proliferate, they need times. Yes, so that's why they have a chronic lesion. And the second one is hemorrhage. So hemorrhage usually is a more acute lesion. But in this case, hemorrhages in terms of liver diseases, they are associated with deficiency in prothrombin formation, deficiency in fibrinogen, thromboplastin, and a consequence of prolonged of the clotting time of the blood occur in hepatic diseases. So failure of those clotting might lead also to hemorrhages of the patient with hepatic diseases. Okay, so that ends with lecture on the hepatic diseases. So before I move to the practicals, any questions so far? Okay, yeah. So we end our lectures on GIT, and now we move to our practical 3, yeah, and we focus more on the liver. Okay, I'll try to find the slide. Okay. Stop sharing. Okay. Hold on a second. So we go first to the practical schedule. Okay. I'm not sure I'm share or not this one. Can you see the practical schedule on the screen?
No problem. No problem.
Oh yeah, hold on a second. Now maybe something wrong with me. Wait there. Okay, maybe now yes.
Yes,
How about
Prof.
now?
We can see now.
I can see now, yeah. Thank you very much. So we just move into the liver, yeah. So again, with regard of these practicals, again, I put there in terms of first is in terms of liver. Most importantly, when talk about liver, you must know that the main cell of the liver is hepatocyte. In the intestine is the enterocyte. And then we discuss about the structure as well as the lobular pattern, yeah? Where we have lobules or lobular unit, preportal lobule, mid-zonal, or central lobular. These are the old classical function. And zone 1, zone 2, and zone 3 are preportal, mid-zone, and pre-athena zone. And this is in terms of, they are not very critical, but I mentioned earlier, they are important partly when you come to read the books, they have different description there. Then, more importantly, you look in the portal tribe, okay? Because the portal tribe, when you look the hepatic parenchyma and the histological examination, first what you need to do, of course, you have to identify. Whenever you do histology, the important part is for you ability to recognize the type of cell. For example, a slide given to you, how do you know that piece of slide actually is a tissue piece from the liver? So that's why the most easier sometimes, if you're not able to see the hepatocyte, probably you see the portal tribe. So, oh, this is a portal tribe. Then you look carefully, then you try to recognize the presence of hepatocyte and sinusoid. So you know there's a liver. Of course, in normal condition, with this non-diseased liver, it's easy to look, you know. But in the diseased liver, so sometimes the structure of the cell is completely different. Not ever you see in a normal liver. So that's why determining the cell is so important and type of cell present there. And even when you examine, for example, where it's a metastatic tumor, for example. So we can see that actually the cell is completely not hepatocyte, something else, maybe lymphocyte. But yet you can foresee that there will lymphocyte infiltration or invading the hepatic parenchyma. Then you can start under, yes, this is actually the liver, and those neoplastic cells actually more of a migrating or secondary neoplasia into the liver. Okay, anatomy, histology, for all organ, for you to remember, for you to appreciate is very important because this is the fundamental. By knowing so, it's much easier for you to understand when you study diseases, even when you study what you call it, medicine and so on and so forth. Because you can imagine how actually the mechanism, the responses that might occur on those of body system. So if you cannot appreciate, then you might not able to appreciate more in terms of medicine and even surgery and many other things. So that's something that very important. And I mentioned earlier, in maybe less severe organ, it's easy to identify. But in cases of disease organ, it's more challenging, and you should be able to identify those type of cell. Hepatocyte in the liver, we present a portal tribe, and with the central vein, that will help you to identify the organ and later on to come up with a proper diagnosis. This will be repeated many times. I will mention to you many times. We always repeated during the lectures and even later on during the practicals, during the case study. I'll repeat again here is that when you look at organs, first you have to identify what organ is it. You must be able to do that. Yeah, this is very important, whether grossly or histologically. The most important thing is that you also follow up with what type of changes that occur in the organ. So you have to describe what is the changes. And those changes, again, you refer back. Is it lesion? Is it post-mortem change? Is it artifact? Is it agonal change? And if this is a lesion, of course, those changes involve with 10 types of this to respond to injury. And the common one maybe in regard of circulatory disturbances, like hemorrhage is very common. That one you must able to do. That's very important, fundamental. Only after you able to describe the lesion, and probably later on, if you're able to put the morphological diagnosis, actually the morphological diagnosis is more option, not really very critical, because morphological diagnosis is for the interest of pathologists or the pathology, not really later on for the clinician and so on and so forth. But yet, if you are able to do that, why not? It's not very difficult. You're thinking about aging, whether acute, subacute, chronics. You talk severity, whether mild, moderate, or severe. Then you talk about lesion. Is it hemorrhage, ulceration, erosion? Then you talk about lesion inflammation. Yeah. Then after that, just talk about location of the organ. So it's very straightforward, not that very critical. The only thing is that your ability to put that together. Yeah. And then when you're able to put morphological diagnosis, I mentioned earlier, the next step will be what you have to ask, what caused this lesion? What caused? Is it bacteria? Is it virus? Is it infectious? Is it non-infectious? Yeah. And based on that, after you have that, then only you're able to put your possible etiology, and those etiology, then you can able to put your differential diagnosis, because differential diagnosis is a disease. Yeah? It's a disease, but etiology, we call it as etiological diagnosis. So if you're able to do the etiological diagnosis, then you can come up with a differential diagnosis. Of course, your ability to come out with etiological diagnosis and a differential diagnosis is based on your ability to identify the lesion. Yeah? And when you necropsy, for example, apart from I mentioned earlier, what you call it, agonal, artifacts, postmortems, and lesion, got 4 there. The lesion usually classified as 3 types of lesion. When you look at it, then you start away to think of a 3 types of lesion. First, common lesion. Congestion, I mentioned earlier, is common lesion. It can be caused by anything, can cause congestion. It is common lesion. Then you start to think of the second one is important lesion. Hemorrhage is very important lesion. Yeah, they are important lesion. They must be caused damage of blood vessel due to something. But congestion can be caused by many things. Yeah? So they are less important. Yeah? But even now we just take our lunch, okay, our stomach, blood vessel we engorge actually. Although the engorgement more involve the artery rather than what you call it, rather than the vein, but it's engorged also. And it might be look gross congestion. And they meaning nothing, but they are important. They are lesion, but less significant with regard of to relate lesion with the agent or maybe differential diagnosis. But hemorrhage, yes, they're important lesion. But suddenly you see hemorrhage, and that hemorrhage, or actually, if you talk GIT, is a present in the cecum of chicken. Then that one is almost a pathognomic lesion for Emeria acevallana. So it's more pathognomic lesion. So lesion can be classified as common lesion, important lesion, and what we call it as a pathognomic lesion. So after knowing the type of lesion, after knowing the cellular damage that involve, for example, in this case, they involve of damage of the hepatocyte, for example, necrosis of hepatocyte, presence of intranuclear inclusion body in the hepatocyte, hemorrhages in the hepatocyte, within the hepatic parenchyma. So based on that, you might able also to think of what type of clinical sign. So damage of liver, hepatic, you can lead to hepatic jaundice, yeah, the one of the jaundice. It can be also leading to failure of toxification, disturb the central nervous system. Yeah, and then of course those damages also could lead to clotting defect and other things like mentioned. We have about 5 what we call it clinical manifestation of the liver diseases. So you must able to relate between the lesion and the clinical sign. And finally, I mentioned earlier, you are able to do the pathogenesis, where pathogenesis actually is how the agent get into the host. From there, they go to the target organ. Then there will be necrosis or cellular response of the target organ that will lead to functional abnormalities and finally lead to death to the animals. So this is a basic fundamental of pathology. Yeah? So I always repeat it because to me, this is the most important one. The rest we can just follow, and sometimes the pattern and the program or the mechanism of cellular necrosis, with some or different agent, they might be about the same. Yeah? Question class? Any question? Ada soalan? Tak ada ya? Risau pula you tak ada ni. I hope you're fine. Don't worry. So we have all the slides, the infection hepatitis, episodic hemorrhagic diseases, inclusion body. This slide also same slide in the what I call it in the lectures, but my main concern when it comes to practicals, you have to form this. This is very important, yeah. Meaning that from each slide, this is different from the lectures. Lecture will explain to you, for example, how the copper poisoning develop, yeah, pathogenesis of copper toxicity. But when it comes to practical, you need to put your write up of those information to ensure that you understand, because by doing so, then you can remember better, and more importantly, it's more practical, and you have more ability to come out with diagnosis as well as pathogenesis and mechanism of cell damage. Okay? This one is again a historical slide. As I emphasized before, when you have this type of history of the slide, this is a process of making diagnosis. And when you make diagnosis always based on history, clinical sign, lesion, and the agent, identification or characterization of the agent. So when you see this type of question, straight away, you look what is the history. So the important history here given is that, of course, the animal is a dog. Meaning that if it is dog, the disease will be disease of dogs. Not disease of cat, not disease of cattle. It's a disease of a dog because dog died. Then they give age, that is, they are 4 years old, means be adults. And the organ is liver. So this is history that given to you. You know it's a dog and adults, they have liver. So we can think of what is common diseases of dogs. But at the same time also, in the clinical sign given there, animal is vomiting. So those vomiting seem to be non very specific clinical sign, yeah, but they have vomition there. And then you got the history, you got clinical sign. I mentioned to you the third one given to you is a lesion. Necropsy means gross lesion or histological lesion. So they give you a very non-specific. The liver was congested. Yeah, was congested. So meaning that people do the gross examination cannot appreciate in terms of what you call it, a lesion of the liver, and they only appreciate is a congested. Okay, don't worry that describe the physical changes in the organ. But another one, if you are given a slide, so meaning that you need to describe those are the changes, what happened. But more importantly, in this case, you are given guidance that also they are present on intranuclear inclusion body, and the prenasal necrosis and hemorrhage. So in this case, you are being guided that this is a case of infectious canine hepatitis. But probably, if what I call it, not exam question, but probably the information of history, clinical sign, gross lesion, plus histological lesion given to you, but in this case, they are so specific. First, you might ask, please write the morphological diagnosis, for example. Yeah, what is the morphological case? Or please list the lesion. You have to look at the lesion there. Then you might ask probably also what I call it, describe the mechanism of intranuclear initial body development. Yeah, this mechanism. Describe the mechanism of hepatic necrosis. Describe of mechanism of hemorrhages in this case. The mechanism. Then the follow-up from this, if you give the history just now, you might ask also maybe what is a pathogen, what is most likely. Yeah? In this case, you must be asked for most likely because the presence of intranuclear initial body. What is most likely? What is most likely disease in this case? So most likely means the lesion or the information given to you with regard to history, clinical sign, gross lesion, and histological lesion. The histological they have very important or maybe pathogenic lesion. So that's why you might not any mistake that it is a case of infectious canine hepatitis. The follow-up will be, apart from the mechanism, pathogenesis, you might also ask for cause of death, for example. Yeah, then you have to write how actually the animal will die off in cases of canine hepatitis. Okay, ada soalan? I just get you familiar with a type of condition where the history, clinical sign, gross and histology lesion are given to you. Do you come out with diagnosis? Do you to come out understanding on the mechanisms? Do you come out with understanding of the pathogenesis? Just based on the information given to you. Okay. And this also, I'm thinking also that your ability to have a critical thinking. When you look a case, you look an organ, look for the lesion, your mind is active of asking us those information. Okay, so your learning process is more towards of looking for information, looking for knowledge. So that will be better, yeah. Okay. And the second one again is liver, but it's from adult rat. This is a history, and they are given also the information regarding the size of these cystic nodules. Yeah, but of course in this case, what given to you is more of the history adult rat. You are not given any clinical sign there. You are only given cystic nodule. And then you need to describe particular changes because it's histological slide. What is important, your morphological, differential, probable etiological. And we need to see also the nodule and the presence of eosinophilics. So when eosinophilic, usually eosinophilic cell or inflammatory cell are associated with parasitic infestation or infection, or many times also as a result of allergic reaction. Yeah. Then you have what you call it other slide that include or inclusion bodies, fasciolosis, and others. So this is mainly on the liver. Yeah. Maybe you can let on briefly go through the slide of this practical tree. Class, any question? Tadi, you have any question?
No, Prof.
No problem.
I hope it's clear. I try to make you clear on this. So okay, I'll try to. We will go to the following slide. We have to need to stop sharing. Okay. Yeah. So we have practical tree. Okay. Oh. Wait a second. Yeah, I don't know whether you mean or not. Wait first. It goes to the case study. It's okay. I think we go to the slide first. No problem. This case study. There are two slides here. Is it on the screen? Again, can you see the slide?
Yes, Prof.
Okay. So this is a case study. When you go to case study, we are still the same. Yeah? The approach is still the same. The only thing that is what you call it, we thinking that your ability to understand better. Yeah. Wait first. I'm not sure why the appearance are different here. Okay, maybe now better. Okay. So if you look carefully here, of course, this is very, very, normally I give you very clear because the clarity make you to understand how actually you need to work out. Yeah? For example, in this case, I mentioned it's a real case. First case of inclusion body hepatitis, IBH, yeah, in the chicken is about due to adenovirus. So in this case, you are asked to describe the gross lesion, the gross. This is the liver, isn't it? I think I discussed already during the practical class and during the lectures. Maybe you can try to describe it, yeah. And you want to have very good guidance of this description, you can always refer to your practical notes that I given to you on necropsy. Yeah? Then come up with molecular diagnosis. I think most of you are very good on doing so. But in this case, very simple. They ask you about name the most likely diagnosis. Partly because in this case, the case is very straightforward. And we thought that your ability to identify what is a pathognomonic lesion, although in this case, it can be considered pathognomonic in chicken. So your identification of a pathognomonic lesion, particularly on histology. Because lesion classified as common, important, and the second one is pathognomonics. Okay. And the second one, of course, in this case, again, describe the lesion. You can foresee those lesions. Name the morphological diagnosis. Again, when you come to issue of whether this is acute, whether it is chronic, or is this subacute. If you look at the first slide, this one probably you might thought of they are not acute and they are not chronic, meaning that they are more of subacute, yeah, hepatitis, yeah, inflammation of the liver. Why you say inflammation? Because the organ enlarged, some area hemorrhage, big reddening, yeah, that's why pit for the inflammation. So you can, in this case, you might call it a subacute. But in this case, definitely they are not chronic. So definitely they are not acute. You can see those of excess. So there are two different things when you see there's a dead neutrophil. Some information of abscess. When there's an abscess is covered by capsule. And that capsule comprised of fibrous tissue. Yeah, fibrous tissue. So with that regard, this one is definitely not an acute lesion. So it can be subacute or chronic, but most likely because the presence of those fibrous tissue covering the abscess, they are actually is chronic. Yeah. So very easy, chronic, severe. What is the necrosis? Isn't it suppurative necrosis? The lesion necrosis there. Suppurative necrosis. Out of one, we call it suppurative hepatitis because inflammation of the liver. So differential diagnosis because you thought this is pathogenic bacteria. So any pathogenic bacteria could lead to changes in the presenting of this type of lesion. particularly those of chronic pyogenic bacteria. You are also asked with biochemical changes. So not sure whether you have learned your clinical CP, yeah? Clinical pathology. Have you learned your clinical pathology? Not yet? Yes, you learn CP? Not yet.
Yeah, Prof.
You learn CP? Not yet. Okay, not yet.
No, next
So,
exam.
yeah, I think another important laboratory test for organs, yeah, is a clinical pathology. Clinical pathology. For example, when you see anemia, mental anemia, so you'll expect the PEG cell volume is reduced, isn't it? So clinical pathology is very important in clinical study, or when you are veterinarian in your clinics, try to establish certain degree. For example, although anemia you can examine just based on the pale mucous membrane, but to be definite, you send the RBC into the clinical pathology lab and you're expecting to get what you call it drop in PEG cell volume, isn't it? So that's clinical pathology. Similarly also, when you examine the animal and they have a jaundice, yes, you expect there will be what you call it lesion, whether it is hepatic, pre-hepatic, and post-hepatic. And you need to further confirm that probably is hepatic play more important role to see that there's a hepatic damages, meaning that there's a damages of the hepatocyte. Again, you can send a serum also to the CP labs and ask for liver enzyme. Yeah? Liver enzyme depend on different species. So normally when the cell of the liver undergo severe degeneration or necrosis, the liver enzyme will escape. And when they escape, then the liver enzyme concentration in the serum or in the blood will increase. So when you take the serum, you submit to the laboratory, so we'll detect that there's an elevation of the liver enzyme. Yeah, particularly example as SGPT, SGOT will elevated. So that also will help you as a tool when you are in the clinics to get some information on how severe actually the liver lesion. And then based on the value of those elevation of SGPT, of SGOT, this is a liver enzyme, probably you can classify and get some indication because a certain value, they might be severe, with the moderate or mild. I purposely put there what I call it, the biochemical changes, although you have not learned, but for you to understand that apart from histology, grossly, but apart from physical examination, look at the clinical sign. Another tool that you can assist you to look organ damage, to look how diseases or agent could lead to necrosis, degeneration, or other lesion in the organ is by what I call it biochemical changes, or many often is the clinical pathology. So you can do that. Yeah. Okay. So in this case, of course, you expected to see elevation of SGPT or SGOT, depending on it's a cow. Any question, class?
No question, Prof.
Okay, that's how to bring you also try to relate with others apart from the, because otherwise it's less interesting. We need to relate with other subject as well. And then in this case, okay, again the buffalo that we have. Again, you ask morphological diagnosis. So in this case, we got two different changes now. We might I might refer to the first slide, and then have to refer also to the second slide, because the changes are different. The message is actually very clear for you to differentiate between fibrosis and fibrin. There's a more important message. In this case, it's a fibrosis. It's fibrous tissue as a result of larva migration of flukes, liver flukes. Again, I'm still asking you the name of morphological diagnosis. Again, we are referring to severity, age of the lesion. When you have fibrosis there, it can be acute or subacute, maybe acute, maybe it can be, sorry, it can be, it can subacute or chronic, I'm sorry, because of fibrous tissue there. So it can be a, what you call it, subacute or chronics, most likely chronics. Your ability to do aging that, and in terms of severity, in this case, maybe they are only moderate. And what lesion there you can see is a fibrous tissue. You can see also the liver and inflammation, hepatitis, we call it hepatitis. And when you see that the lesion is located at the capsular surface of the liver. And then it's more difficult, in this case, not being discussed in class. But of course, you learn pathology, how actually this lesion developed. Of course, this lesion is developed as a result of migration or larvae, isn't it? During the development of adult fluke. So that one you might refer or speak on the pathology. Pathogenesis also, again, is involved with how the lesion developed, number 3. But when it comes to pathogenesis, they still need how the animal die. So how animal die off as a result of this liver fluke. Whether it is primary, liver fluke alone can cause death. And normally there's a lot of liver fluke resulting of the hypoproteinemia, or any fluke can cause those blockage very severe, or necrosis hepatocyte. Anyhow, this liver fluke can kill the animals. Although many instances, animal might not die of this liver fluke infestation, except for very severe infestation. And then describe the expected clinical sign in the animal. So when you talk about what you call a common one, of course, jaundice might be there because of hepatic and post-hepatic. Then the possibility also animal have hydroperitoneum as a result of hyperproteinemia. Then they might have also very seldom what you call it clotting defect, but not likely they have clotting defects. But most time, in cases of buffalo with liver fluke, they have also the edema. Okay. Then in this case, liver of sheep. Okay. And in this case, liver of sheep, again, describe the lesion. Differential diagnosis, of course, anything that can lead to jaundice. Pathogenesis, I discussed with you this morning regarding the how copper lead to lesion in the liver as well as in the blood. You're asking about biochemical changes. Okay, it's a bit general. These biochemical changes also involve with the liver enzyme. This one we have again in sheep. Describe the gross and histological lesion. You can see those vacuole there. Actually, it's a fat, isn't it? Multiple diagnosis, and describe the mechanism of lesion development. Okay, in this case, they involve more of gluconeogenesis, where animal to utilize fat for the source of energy. And as a result of that, there will excessive accumulation of fat in the central vein there, or zone 3. And in severe cases, of course, those vacuole of fat might lead to disturbances of normal liver. This is the same thing, but in this case, you can foresee your ability to differentiate the degree of lesion. Yeah, when you describe there, the top there is acute, but the bottom one there, you might say acute, but they are not chronic, and they are also neither acute. Yeah, so they are actually is a subacute. You're asking about development of lesion. Remember what they do is more of a severe hepatitis and push out of fibrin from the organs into the surrounding. And it tend that you also describe on the diagnosis of the disease. Yeah? Okay. So again, when you talk about diagnosis, you are talking about your history, clinical sign, you have gross lesion there. And in this case, when you have to diagnose, but in this case, you suspect more towards a bacteria, then you have do bacteriological examination and then isolation and identification of the agent. And in this case, most time you're going to isolate E. coli. Okay. So I think this last one, more on the neoplasia. Sometimes an issue comes when you look at the lesion, there's some bulging there. How are we going to differentiate this bulging between neoplastic tissue or it is an abscess? Okay. Sometimes it's quite difficult, not that easy. Yeah, not very easy. We might make, I mean, if you thought this abscess, so it's nothing wrong when you do under the just slide. Although you look carefully, in cases of neoplasia, you don't see capsule then. Capsule, because in cases of abscess, this area will surrounding by fibrous tissue. So it's more capsular. Then inside there is abscess. And all the time when abscess occur, they are yellowish, but in this case you can see different color. Yeah, some yellow, some liver color, and so on. But I don't in terms of what I call it gross lesion, it's difficult to differentiate. But you have some degree of ability to differentiate based on what I mentioned earlier. So name the differential diagnosis. That's why when you have differential diagnosis there, you can have the differential diagnosis as what I call it neoplasia, but you can have also differential diagnosis based on pyogenic chronic bacterial infection, like tuberculosis, myeliodosis. All those can lead to about the same lesion there. But number 3 is a bit tricky when you ask how you differentiate the disease name into or the condition name into. The idea is that I mentioned earlier, how you going to differentiate between those lesion caused by neoplasia and lesion caused by pyogenic bacterial infection. The most likely diagnosis, this one, well, if you make mistake in this case of the likely diagnosis, you say it is bacterial, just based on this slide, it's not wrong with you. But of course, when you put it as a neoplasia, you are more correct. And how this disease is formed, okay? Because the pathogenesis. I mean, the pathogenesis means how the disease will form and interfere. The abnormal function will lead to death. So that is the what I call it, the next tutorial. So this next tutorial is option to you. You want to try to do, you can. But our focus after this, we try to look at your, what I call it, your second tutorial. I'm going to work out on that. Is it okay? So can we have break 5 minutes? Then we go to the tutorial. So we back at 10 past 3. Yeah? Then we go to the tutorial. Okay? Is it okay?
Okay, Prof.
Okay, Prof.
Okay, thank you.
Prof,
Yes.
I'm sorry that I forget to ask, but we don't get the practical and case study for A3 yet.
Hold on a second. Oh, sorry. I have not submitted. I have not forwarded to you.
Not yet.
I'm so sorry. Okay. Because I thought I given. I will give you later. Yeah. Because I thought I given you this morning. Not yet.
Not yet, Prof.
Minta
sorry
maaf ya.
I
Because
forget to ask
this
you.
morning I got meeting. I thought I given to you already. So I will email you after this. Is it okay?
Okay, Prof. No problem.
I am so sorry for that. I terlepas pandang. Ini kan sudah bagi. Okay. I email you after the class. I can email you after this while waiting for the next class. Yeah, boleh?
Thank you, Prof.
Welcome. Okay. Can you hear me?
Yes, Prof.
Yes,
Okay. Okay, because I'm not sure whether I'm out system ready. Out just now. You can hear, then I can start maybe. Hold on a second. To share this one. Can you see the PDF there on the screen?
Yes,
Yes,
Prof.
Prof.
Okay.
Yes, Prof.
Sorry, Chong, this is yours. But just because I see that got some photo there, so you include the photo there. Maybe to start with the first one is better. So we continue. We look carefully there. But in this regard, I just email you the what I call it the practical class as well as the case study 3. Okay. So when you look carefully here, I mean, of course, in this case, the first important thing, this one may be quite easy, but when you the first one here, if you don't give us intestine, you don't know whether this intestine is something else. So that's why purposely they put off the intestine. So more importantly also in this case is from a cat. Meaning that when a cat, this must be a diseases from a cat, not from other species or animals. And this lesion, I think quite clear that you can see the intestine. When they open, you see that a lot of reddening. Well, when say reddening, this is more of blood ooze out. But not only blood ooze out, but more on the darkened red is more of clotted blood, isn't it? So you can see that when on the cut surface of the intestinal lumen, you observe what you see more of watery as well as reddening and clotted blood inside the lumen. Some of you, when you see the watery, there could be some edematous also, but more importantly, those reddening and the clotted blood is associated with hemorrhage. Because those type of changes also can be as a result of maybe if we got any changes of what I call it postmortem change. But in this case, you can really see that the clotted blood there is very darkened, got hemorrhage there. Lesion maybe there's a watery fluid there. You don't expect to see other. So it's really you can see that the reddening, hemorrhage is more of hemorrhage, and second lesion is inflammation. So the lesion present there, in simple term, is more of a hemorrhage. Our description is lesion is hemorrhage, description is reddening, and clotted blood, and enteritis. Okay, so open. But in this side also, this more on the serous surface. But in this case, we have not opened the lumens. The lumens not been opened. And the location actually middle part of the intestine, isn't it? Okay, in this case, you can foresee that there is a appearance of reddening of the intestinal tract at the middle part of the intestine. And that reddening is sometimes quite difficult. If you talk about lesion, it can be a congestion, but it can be also what we call it hemorrhage. So probably at this stage, still made feeling whether they are congestion or hemorrhage. But when you cut like this, they're more clearly that they are hemorrhage. So let me look at the answer what you given. Okay. This is description of lesion. I think correct that you put a staining of ingesta with blood. Correct. This is the description of lesion. What you see there is more of staining of ingesta with blood. You thought those clotted blood is more of the ingesta. It's nothing wrong. Okay. So it can be a clotted blood. It can be also the ingesta. Okay. And you put that indicate hemorrhage. Hemorrhage lesion. But the staining ingesta is blood. Then you find reddening, edematous, Actually, when we talk about inflammation, I already mentioned it. What is swollen, redden, then is painful, and heat. Because in this case, you are not able to have all those criteria, but redden is there, and I think looking at the open, the cut surface of the intestinal lumen, really it is what I call it, really fit with the enteritis. So, in principle, of course, this is a track description. Although when you go to the second part here, you have to mention bit on the medical we call center or middle part of the small intestine. Okay, very good. Then we are able to, in this case, you are able to describe the lesion meaning, and you also are able to classify or put that lesion to put it as what I call it enteritis. The lesion there is hemorrhage and enteritis. So aging, when you look at aging, of course, they're severe. So this I can consider full mark, as simple as that. Yeah? And then when you look at the lesion that is severe, oh yes, I think this is very severe. You cannot say it's acute. Is it not severe? It's mild or moderate. It's very severe. That. And you put brave enough to say acute. Yeah, they are acute. Yeah. Although I mentioned here, you can classify as subacute, but looking at how fresh is it, they are acute actually. And you put hemorrhagic enteritis. In this case, you prefer to put in the mucosal surface of duodenum or the small intestine. Yes, it can be duodenum and can be a duodenum. And of course, that will be good. So, very good example. A model of morphological diagnosis. You are able to put the modular axis in a correct form. They are right there. It's good. Okay. So I think the rest you look yours, whether you are in the right direction or not. Not only happy, I'm also happy to see those. Yeah? Then the second one is mechanism on lesion development. Meaning that the mechanism of lesion development is actually how this severe acute hemorrhagic enteritis at the mucosa or duodenum develop in. Okay, up to that level, they are not a pathogenesis. Just try to ask how actually, what we call it, severe acute hemorrhagic enteritis at the mucosa space or duodenum of intestine develop. So when you talk about development lesion, it will start with the agent, isn't it? What is the agent? And how this agent will enter to the host and causes damage to the cell. In this case, damage on enterocyte at the duodenum. How this occur? The flow. Yeah. So in that case, you have to look back the history. The history is intestine. The animal is a cat. So it must be to do with the disease of cat. Yeah, meaning that you cannot put there as infectious canine hepatitis. Canine is a dog. Yeah. In this case, you have to put a cat. You are correct there. You put there feline panleukemia virus, or they call also a feline parvovirus. So what we can see here, based on the lesion, you're able to describe, you're able to put morphology, and now you're able to put also the potential agent that can cause that. But in this case, you can have other different agents also, but in this case, you are more specific and choose as parvovirus, where you are right. The other intestinal knowledge is that which is not taught so much on the lectures, yeah, or been written so much on lecture. We taught it, but not been written so much, the pathogenesis. So you try to come up with how actually this virus will enter the host and they develop a lesion. So you put there, what I call it, parvovirus, enter the host, most likely via fecal oral route. Then they invade the oral cavity. They can go to pharyngeal lymphoid tissue again. They got lymphoid cell there. or they can go also into the pia patches of the intestine, doesn't matter. But they have to enter the lymphoid tissue. Then they can cause viremia. Perfect. I mean, if enter, then they multiply in the lymphoid organ, then cause viremia. And when this viremia, of course, the virus has tropism in actively dividing cell in the crypt or lubricant small intestine. So they go to this small intestine through viremia and cause damage of pregnatal cell. Mean they will damage all the crypt or lubricant. You can use the word damage. You can put there. It's nothing wrong. Damage is no problem. You can use further when you enter the enterocyte in the, because in this case you didn't put the cell. You just dividing cell in the crypts. Actually, when you say intestine, your answer, I mean, you can get a full mark there, no problem. But it's more beautiful if you can put it as a enterocyte, because the epithelial lining of intestine is enterocyte. Okay, you don't put any enterocyte there, so at least you know what is epithelial lining. So they can cause damage of the enterocyte, is a pregnatal cell. And in this case, actually, there's a few school of thought. When the damage of the pregnatal cell, I don't want to make you so confused. Sometimes they always direct to cause villus atrophy, what you mentioned here, where there will be pregnatal cell damage, there is less production of enterocyte or immature cell, so replacement resulting in shorten of villi. Okay, so that's right. I mean, sometimes in very frank or less severe case of virus that they cause, but the only thing is that at the same time you put here the cause, at the same time also the necrosis of the enterocyte in severe case could lead to superficial blood vessel damage or the blood vessel damage, causing acute severe endothelial damage, and then the damage of endothelial cell leading to hemorrhage. Okay, and as a result of that, you can see that response reductive enteritis, was irradiating endometrial appearance of the intestine. So yes, the answer is correct. Okay. Although many form or approach that you can have, but this one is very clear that how actually the agent enter to the host, they multiply in the lymphoid organs, then they go to the target organ. In the target organ, they cause necrosis, as well as damages of the what I call enterocyte, necrosis enterocyte, as well as necrosis of blood vessel, leading to enteritis and hemorrhage. Question, class? Any question? And then maybe you form your answer. You're not very sure. Very good. Yeah. I'm taking by random. Actually, I go through all, but I just go random. I'm not choosing actually. I read a brief to all, but I think overall is quite satisfactory. Yeah. Ada soalan? Ada soalan tak?
Tak ada, Prof.
Tak ada ya? Kalau tak ada, okay, we continue. And then you got, cuma yang kat sini pathogenesis ni, kan dia ada sikit kita kena, because in this case, when you put the pathogenesis, describe the pathogenesis of the disease now. Careful ya. The answer there is describe the pathogenesis of the disease. Maksud dia, in this case, the question is actually how actually disease is in this case a feline panleukopenia, isn't it? So you start here with hemorrhagic enteritis. You are right, nothing wrong, but probably remember pathogenesis might start from the agent. Yeah, meaning that there might be some repetition of your question number 3. Then you have hemorrhagic enteritis. Yeah. So meaning that in this case you might lose some mark there because you don't have a complete set of pathogenesis. What your pathogenesis there is until development of villus atrophy. Yeah. Okay. So you need to include how the virus enter to the host, multiply lymphoid cell. Then after that, you go to the target organ where it's a crypt or lubricum, then necrosis or enterocyte, and as well as what I call it necrosis or endothelial cell, leading to hemorrhagic enteritis. or here. So you are missing the upper part there. I do understand. You always thought that the upper part is in number 3. But you have to put also in number 4, although some repetition, because you are talking about pathogenesis. Yeah. So pathogenesis might include the agent, how the agent get to the host, causing a lesion, in this case hemorrhagic enteritis, or you have that due to viremia, due to the, yeah, but not, you have that, tapi tak berapa clear, yeah. I mean, you due to viremia, you're correct. Due to the FDV infection, but you should make it more clear, like you describe in number 3, yeah. Because in this case, you're correct, hemorrhagic enteritis, due to the normally when you do, maybe it's cause of death, due to the what we call it, feline virus infection, or feline parvovirus infection, cause venous atrophy, impair normal intestinal function, result bloody diarrhea, correct, leading to dehydration, reduction in blood volume, cause reduction venous return, reduction cardiac output, hypovolemic shock, low oxygen supply, hypoxia, ischemic necrosis, central nervous system, affecting cardiocenter, center, leading vital organ failure, such as cardiac failure, and death. Yeah, you are right. Again, you are right there. The only what you need to improve to get, you talk about exam, better mark is you are looking on this, you're so get viremia to, what you call it, parvovirus infection, feline virus infection. By right, you should follow the upper part. Maybe with more of summarize, will lead to hemorrhagic enteritis, and this hemorrhagic enteritis you mentioned just now leading to venous atrophy, impair normal intestinal function. Okay, can you follow me?
Yes, Prof.
Yeah, main pathogenesis the package tu dia mesti kena ada agent, kan? Then you have the agent here, memang ada tu. Tapi in this case, you did mention actually how the agent get into the host. Probably because you have mentioned already on your question number 3. But what I call it, in this case, you have to repeat again because we try to understand what is your understanding on the pathogenesis. Yeah. So we have to repeat. You have mentioned here some, but we need slightly more detail. The ideas of, because when you ask about pathogenesis, apart from ability for you to answer the pathogenesis, we try to see you also understand the concept of pathogenesis. Yeah. And then finally, you go cause of death. This is only reverse of pathogenesis. You can prove that the cause of death is due to cardiovascular system failure, ischemic necrosis of the central nervous system, due to hypoxia, due to necrosis, ischemic necrosis, due to hypoxia. Okay, hold on a second. Actually, got ischemic necrosis central nervous system is hypoxia actually, yeah. I mean, because it's reverse. And due to, I think those hypoxia due to nervous system, yeah, probably possible also, but maybe not that critical, the hypoxia here. According to hypovolemic shock, due to reduced cardiac output, due to venous return, due to reduced blood flow, due to dehydration, due to diarrhea, due to hemorrhagic enteritis, due to viremia, and due to what I call it, feline panniculum. Yes, your cause of death, so that I consider is right. In the flow, yeah. So thank you very much for this answer, yeah. Ada soalan tak? Any question?
No problem.
Any maybe we can look, maybe kalau I can share one more for the same one with whether we the same answer or different answer. I need to share, isn't it? Sorry. We just see the same question. We can move to the next question just now, no problem. But please share for the same question first. What others answer, yeah? And this one. Whose first paper this? Those that not been selected, don't worry. Yeah, I need you to understand. But of course, I'm look to your paper also. This is right. This is okay. No Fikri, yeah. Okay. In this case, they put that deletion is reddening, darkening in the part of the cat intestinal tract. This is also a congestion with thick, wet, coagulated blood indicating inflammation, severe hemorrhagic enteritis. Yep. You managed to have the same there, or those different there. Then you have severe acute hemorrhagic enteritis. Yep. Okay. And then you can see in terms of lesion development, parvovirus infection, ingested animal, they will travel inside the gut tract and intestine. This one is something that we be careful. You put the virus replicate inside the enterocyte. You are correct, but in this case, hold on, yeah, you have when the animal ingests the virus travel inside the, you are missing about the lymphoid organs, yeah. Because for viral infection, they need to multiply first in the lymphoid cell. Okay, they cannot go direct, yeah, because they need to multiply first. Then only they can able to have enough number proliferation of the organ in the lymphoid cell, and even those lymphoid cells also sometimes can be a carrier for the virus to go to the target organ. So you miss bit on that part, but still acceptable, I guess, because you say make inside the enterocyte. Yep, you're right. You use the word enterocyte there. It will become cause enteritis. Severe, there will be the blood circulation leading to yeah. Okay, you are talking about secondary viremia. Then the enterocyte will damage or the blood vessel causing blood to leak or hemorrhage develop. The virus intestine undergo erosion and shortening cause of rate of absorption. Okay. Maybe the word erosion there not very accurate, yeah. Okay, because normally in the intestine, well, the erosion means something different. Erosion is more dominant in the stratified squamous epithelium. Okay, so in this case, the intestine undergo a necrosis, yeah, and shortening and loss of the absorption. So what is missing here? One is irrigating the lymphoid cell. Other than that, what is additional where you put enterocyte, and the same time also you mentioned about the secondary viremia. Both is acceptable, yeah, both acceptable. Cuma miss sikit point tu lah regarding the what you call it, the lymphoid cell. And most of the time, the mechanism of most of the viruses they are about the same. Yeah, about what we are discussing now. Then the pathogenesis in this group there. In this case, it starts with parvovirus. Okay, then get ingested, travel GI tract will. I mean, this is something that we need to. There's some repetition. Repetition, of course, is needed because you're asking about pathogenesis. You got the parvovirus there, enter to the host, go to IgT, infected the enterocyte. Because when you put there, when the virus enter the gastrointestinal tract, will infect the enterocyte. What is the difference here is that it sounds that the virus is caused direct infection to enterocyte. You understand? Actually, the virus is not causing direct damage to the enterocyte, meaning they don't go straight from the lumen into the enterocyte. They need to have what you call it, infect the lymphoid cell first. When they got lymphoid cell, they have viremia. Then only from that viremia, they will go into the enterocyte in the crypt or lubricum. Same also in cases of food and mouth disease, for example. When animal ingests the virus, actually the virus, they don't cause straight away multiply in the stratum spinosum, no. Because the stratum layer, the corneum, lucidum, granulosum, all is very thick. Will not allow the virus go direct into the stratum spinosum. They need the virus to multiply in the lymphoid cell first. Because why lymphoid cell? Because the epithelial lining of lymphoid cell, whether it is in lymph node or whether it is in the lymphoid aggregate or PA patches in the small intestine. In the small intestines or PA patches, they have very special M cell, they call it, the enterocyte, they call it M cell. And that M cell is more susceptible for the virus to enter to the lymphoid organ and multiply there. Okay, the first actually they want to multiply, the role of lymphoid organ is as a defense mechanism. But most of the time, There will be a failure, and there will allow excessive proliferation of the viruses multiply there, leading to primary viremia. Then only they go to the target organ. But when you put like this, although you might not think so, but there may be some indication that when you say that the virus travel into gastrointestinal tract and it will infect enterocyte, you might be right. You said it will infect enterocyte after they multiply in the lymphoid organ. But if that is the case, you are right. But it also means that when they multiply, travel in gastrointestinal tract, they straight away infect the enterocyte. Where that one is wrong. Okay. So there is but when I read this, probably I have two assumption, and normally I will put the positive side is that you understand that this virus will multiply enter the GIT and multiply in lymphoid cell. Then they will infect the enterocyte. Of course, you can get full marks, but you are not being penalized so much also, because otherwise your pathogenesis is wrong. Yeah, because they didn't cause direct damage to the enterocyte. Any questions, student? Understand that what I'm trying to say?
Understand, Prof.
Yes, Prof. Understand.
Understand ya maksud dia? In all the pathogenesis, particularly in talk viruses, the viruses usually when they enter the body by oral injection, they are looking for lymphoid cell. Whether the lymphoid cell in this case, you mentioned that lymphoid cell in Holland. Tadi? Yes. You in this in GIT, isn't it? But the upper part you mentioned something, the lymphoid cell in the second. Same GIT also. It can be also in other part of lymphoid cell, but of course in the case GIT, you mean it's they have to multiply there first. Then only they get a primary viremia and go to the target organ. Okay. You are right, but with assumption that if you think that those virus will multiply in the lymphoid cell first before they go to the enterocyte, but you think they go to the enterocyte, you are wrong. Okay. The virus will start replicate, causes epithelial lining. Yes. You can put that. Actually, the word is necrosis. Yeah. Erosion, probably yes, but probably again in the intestine not very clear. But you can put necrosis leading to shortening of the villi. You're correct. Then animal might have diarrhea, vomiting. Then intestine it will be in evidence, distress, anorexia. Severe virus will enter the blood circulation, leading to viremia. It's big, confusing, but well, viremia can occur many times. Yeah? Is another possible. Then you say blood vessel will start to rupture, leading to hemorrhage. In this case, your thought is very confusing. Yeah, they mix up. When this happens, we lose blood, leading to anemia. In this case, there will be low of venous return, leading to low cardiac output, supply. Okay, sorry ya, ni kita komen saja. Not to say wrong, I try to make you very clear. Your thought here is not very clear. The flow, you are still very complicated. You compare with the previous one, kan? The previous one, you are very clear. Your thought is very clear. In the pathogenesis of hemorrhagic enteritis, you are very clear where the virus will enter the oral cavity, then they reply in the lymphoid organ, then there will be proliferation of virus there, there will be primary viremia, then they go into the crypt or lubricum, then they cause a necrosis enterocyte, then they might lead to villus atrophy, then they might lead to also damages of blood vessel. Okay, then there will be hemorrhage. Then you have a hemorrhagic enteritis. So when there's hemorrhagic enteritis, there's many things can happen. If you think that the cause of that is due to the severe loss of blood, then you can say those. I mean that when there's a severe loss of blood, so there will be low venous return, isn't it? I mean, you can draw low venous return. Low venous return will cause low cardiac output. Low cardiac output, I think this explained during the first question, the first example just now. low cardiac output will lead to ischemic necrosis of the central nervous system. Then it will be ischemic necrosis, mean the failure of the central nervous system, probably also the respiratory and cardiovascular center, and failure of the vital organs. That is normally cause of death. Yang kat sini, the flow is not very clear flow. Still right, not big wrong, but still not right. But the thought is not clear because even the viremia you come out 2 kali kan, it's possible. But after all things, then you see viremia, it's nothing wrong, but it's still not clear. But unfortunately, when it come to cause of death, you thinking about animal loss of blood, they lead to anemia. Anemia, yeah. So what is anemia actually? Anemia is as a result of reduction in packed cell volume. Okay, packed cell volume. In cases of anemia, okay, but you mentioned that although it's nothing wrong, you say that there will be low venous return. Yes. Tapi normally low of venous return, not necessarily anemia. Okay. When you have anemia, yes, the possibility of low venous return. Tapi in anemic condition, of course, there will be low RBC. Low RBC means that the mechanism is slightly different because when you have low RBC, there will be low oxygenated blood, isn't it? Low oxygenated blood from the cardiac output. Because anemic, then the blood is less, so oxygenated blood is low. And again, when low of the what you call it, oxygenated blood, so with low oxygen supply to the vital organ, particularly brain, and again lead to ischemic necrosis. I mentioned to you, it's nothing wrong. I mean, it can be right, but your thought is quite complicated bit, not very clear thought, because you choose anemia there. If you choose severe hemorrhage, then you choose low venous return, you're more right. You got me? Can you follow me? Because when you see a severe hemorrhage, of course, severe hemorrhage leads to low loss of blood. And loss of blood will lead to what I call low venous return. I mentioned earlier, yes, anemia could lead to what I call it a small volume of blood, but the mechanism of anemia is more towards low oxygen in the blood rather than low volume of the blood. In hemorrhage, they are more referring to low volume of the blood. When there's low volume of the blood, that lead also low or oxygenated blood present in the cardiac output. So, class, can you any question? Yes.
Can virus ni dia affect creep of liver kan, causing necrosis of villi. Benda tu boleh lead to fluid absorption in small intestine kan?
Yes, can. If you want to put mechanism of villus atrophy, boleh. Meaning that in this case, maybe it's not severe enough, and they didn't cause they cause hemorrhage as a matter, but your focus you want to see that will lead to villus atrophy. And remember, in villus atrophy, in this case, you got classification of enteritis, hemorrhagic enteritis, kan? Tapi kalau you have villus atrophy also could lead to animal loss a lot of fluid, isn't it? So in this case, animal might loss of fluid, animal will loss of blood, loss of fluid because of villus atrophy, so they have diarrhea. But at the same time, there will damages of the creep will become leading to hemorrhages. So you want to put the loss of fluid, then you thought about low venous return, low volume of venous return. That also can kill the animal. Yes, possible. Okay. So the cause of death is depending on how critical you put and which one you want to choose. It's very open, and there's a lot possibility, not only one, based on the lesion that you have. Maksudnya kalau in this case, you want to focus on lesion of villus atrophy, So your flow will be how village atrophy can kill the animals. You want to put, in this case, the flow of cause of death, lesion or condition as a result of anemia, how anemia can kill the animals. If you think that in this case, you want to put what you call it, your cause of death due to severe hemorrhage, so how hemorrhage can kill the animal. Although in principle, that will lead to ischemic necrosis of the vital organ. Yeah, because I mentioned earlier, when there's a death, which comes first? Is it of the brain or is it the heartbeat? Okay. Actually, this is very important question when we talk about halal slaughter. Yeah? I'm doing research on halal slaughter. I think Dr. Mazrina also involved. So when you want to determine what is the point of death, is it the heart or is it the brain? So that also is not easy to determine. Yeah. Of course, it's easier for us to determine the heart because heart beating, isn't it? But maybe it's quite difficult to determine the brain. So, but both can occur together. But based on our pathogenesis, it seems that the end or the terminal will be the heart, because the heartbeat. Yeah? So I mentioned to you when you got the lesion. So the cause of death, the final one, stage of lesion. That's why pathogenesis. First, at the level of agent, the agent enter, then they form a lesion. After we got the lesion, how that lesion can lead to death to the animal. That's the second step of the pathogenesis. You choose as an anemia, the flow is slightly different. If you choose the diarrhea, the flow is slightly different. If you choose hemorrhage, the flow is slightly different too. But all is right, nothing wrong. Question?
Prof, kira kalau we choose pilus atrophy,
Hmm.
pilus atrophy tu can cause severe dehydration tak? Sebab dia kan
Boleh.
berjauhan. So
Boleh,
kalau
boleh.
severe dehydration tu boleh cause death tak?
Boleh. When the animal severe dehydration, so dia punya blood volume, yeah, is low. So as a result of that, they are dehydrated. So the blood volume low. So as a result of that, the venous return also is low. Okay, can. Kadar output also is low. Boleh?
Okay, thank you, Prof.
Okay ya. Maksud dia bergantung kepada apa yang kita pilih. You want to say vomiting pun boleh. Okay. You pun diarrhea pun boleh. Kalau worst come to worst, you talk about inappetence. Remember last time when you talk about food and mouth disease, when they have dysphagia, difficult to eat, animal become starvation, then you have to put your mechanism how the starvation could lead to death to the animal. Yeah. The condition, can dysphagia, I mean they got ulcerative glossitis or ulcerative stomatitis. So how those ulcerative stomatitis lead to what you call it starvation? So the mechanism must be clear. Maksudnya mungkin dia dysphagia, difficult to eat. How difficult to eat lead to apa namanya, lead to death? If you want to apply your knowledge on liver, probably when the animal starvation, they will try to utilize the fat tissue. So there will be gluconeogenesis. There will be very severe hepatic lipidosis, yeah, and that will lead to failure detoxification of the waste products. So I mean, this the flow cause of that actually is very open, but only thing that you have to choose which lesion. Okay, boleh? Oh, no, in this case, your pathogenesis, not cause of death. We are talking about pathogenesis. How the lesion leads to death to the animal. The pathogenesis, yeah? Not check the cause of death. Because the cause of death is reverse of the pathogenesis. Okay? Class, any more question before we move to the number 5? Okay, in this
So
case,
far, okay.
okay, I want to understand. Don't worry. I mean, the answer is right. Not to say you are not right. Even question number 4 is right. You have much better because in this case you include everything. The previous one just now you don't have, but this one you have already. The only thing that maybe your thought of the cause of from the lesion to death is not very clear. Yeah. And when you talk about the enter pathogenesis as now, the enter of the virus into the target cell also not very clear. But mislead, although you might just miss of the lymphoid aggregate, but sometimes it might cause different interpretation. Yeah. Then in this case, you describe the cause of death. Cause of death is caused by failure of central nervous system, circulatory and spleen. Yes, correct. Ischemic necrosis, correct. Ischemic necrosis occur due low blood supply to the vital organ, such as heart, brain, and lung, correct. Low supply of caused by lowering of cardiac output, yes. And that also because low of venous return, correct. Reduced cardiac output and venous return are due to the hypovolemic shock caused by hemorrhage. Yeah, you're correct. Hemorrhage happen due to rupture of blood vessel as a result of, okay, you mentioned the parvovirus infection. Yeah, but it's okay. I think the flow is there, although not everything there. It's acceptable. Your flow of cause of death is very clear. Okay? Do you think enough example or you need one more example?
No, Prof. It's okay.
Enough, eh?
Yes, Prof.
Okay. Kalau enough, now it's almost 4 o'clock. Maybe if you got any last, if you think that we need to do any additional class and so on and so forth, we have another week. I think next week will be free. If you think there's a need, of course, you are most welcome. I can arrange with me later on. The Mazrina will help me with the online meeting. If you think you are comfortable, I wish all the best. Of course, I will see you again later on in your pathology 3. Yeah, I'll teaching on the urinary system. Okay. So
there are 2 questions in the chat box.
Yeah, please. Sorry, one, 2 questions. Sorry. What is it?
Can you give us an example of etiological diagnosis?
Oh, yeah. The etiological diagnosis is actually okay. When you talk about diagnosis, normally when you talk about tentative diagnosis, we are talking what is your diagnosis? You are referring to the disease. Disease. Diagnosis is a disease. Diagnosis of a disease. Okay, mean that the name is a disease, but you are not very sure. You can put also as infection. For example, parvovirus infection. You are not sure that the disease actually is filamentous leukopenia, because parvovirus infection can be a disease also. Yeah, but you're very sure it's filamentous leukopenia. Of course, you are more accurate. Filamentous leukopenia is the correct one. That is diagnosis. Diagnosis is a disease. But when you ask for etiological diagnosis, etiology is a cause, or etiology, etiology is cause, isn't it? So when you talk like in this case, the etiological diagnosis is parvovirus. Okay? The agent itself, the etiology itself, that is called etiological diagnosis. Can you follow me?
So we just take the agent of the disease.
Yeah, that is etiological diagnosis.
What if the disease is not caused by virus or bacteria?
Example, then you copper. If you have copper poisoning, then you say the etiology is copper. You got it?
Mention like copper deficiency or just copper.
No. In the case is let's say in cases of hold on a second, because the disease is copper poisoning. Copper poisoning, poison, poison. So the etiology is a copper. Or you can call thought excessive copper, or you want to put as a copper poisoning so possible. But the word copper must be there. The etiology is a copper, okay, and the what you call it, the diagnosis is a copper poisoning.
Okay, thank you very much, Prof.
Clear? Etiology diagnosis is the agent. What agent caused that? Well, while what you call it, diagnosis is a disease. What disease? Some is very straightforward, like you mentioned that. Okay. Some maybe they're not related with. For example, just now we have a chicken where we have inclusion body. We have inclusion body hepatitis. IBH. So IBH is a disease, but the agent is a adenovirus. Are they completely different that? Etiological diagnosis is adenovirus, but the what you call it, the disease actually is a inclusion body hepatitis. The disease is infectious canine hepatitis. There's a disease. I mean the diagnosis, but the etiological diagnosis is adenovirus. They're completely different, not the same, Yeah? So they are different. That. And even we have feline infectious peritonitis. The disease is a feline infectious peritonitis. There's a disease. I mean the diagnosis of a disease. Diagnosis is feline infectious peritonitis, but the etiological diagnosis is a coronavirus. And it's different, isn't it? Can you follow me?
Okay, thank you, Prof.
Okay, thank you. Anything else?
Prof, sorry. Prof, can you also check the other document as well, my part, for the question number 1?
Yes, which one?
The other document, the one I submitted, Prof.
Oh yes. But I've been in term. Yeah, I have. That's why I am not managed to do everything. So what we need to do by doing this example, you can look part also what is your case, you know. But if you think that you want to clarify certain thing, you can ask. Because I'm sorry that I cannot go through all the 100 over what you call it answer, yeah, to show you. That's why I just choose randomly. Actually, I'm choosing 3 randomly. And then during my presentation, if your answer is not as what it is, and you get some doubtful, you can ask. Then I try to give you the answer. You understand?
Prof, no. I mean, mine is the third document there, the one you selected.
Oh.
Prof, it's okay. If you're rushing, no problem at all, Prof.
No. I'm fine. No problem. Oh, the third one is yours. Okay, sorry. Okay.
Prof.
Okay lah. Is it? Can you see that or not?
Yes, can see.
I can see. Okay, sorry.
Thank you so much, Prof.
Oh, the third one is yours. Sorry. You can see from the side. I'm sorry. So in this case, serosa surface, middle inserted appear edematous and hyperemic. They are present slightly enlarged. This one is question. Same, okay. Okay. Hold on a second. But why this case you have lymph node also? Sorry. Sorry, I'm not. You say okay, you're correct there. The middle part of my intestine appear to. Oh, you are looking at the what you call it? You are looking this one the unexposed space. Or you are looking those or not on the cluster phase, yeah. So you correct there. Middle part of intestine appear to be. Actually, edematous is a lesion, you know. Hyperemic also is lesion. You can use this also, but sometimes when you but you need to describe the lesion. Edematous means you see there's a glistening appearance. A hyperemic means a reddening. Yeah, they haven't got the word because the hyperemia is lesion. Then slightly enlarged mesenteric node. Enlarged mesenteric node, you're right, because the enlargement could be inflammation, could be also other unknown specific enlargement. Hemorrhage actually is a lesion also, but can be accepted lah, because sometimes I do understand students have difficulty to differentiate between description as well as the lesion itself. But in principle, when you describe, normally you use layman term, but when you start to use a lesion, it will be accepted also. But best you look at the previous one, they say reddening only. You don't put reddening, that's why we call it hemorrhage. The lesion is hemorrhage. Hemorrhage in mucosal, you're correct, and content appear watery, dark color red mixed with sloughing of the epithelial cell. Okay, the description is fine. Okay, the only thing that I mentioned that you use the term of lesion, but acceptable. You put the severe acute, locally extensive, hemorrhagic. The accelerative is big questionable, but because you don't clearly ulcer. Although if you thought that probably those are the space we have between the blood clot, it's more like more of small lining there in ulcer. probably we can be accepted, because when you look at ulcer, remember that the button ulcer, the appearance and the distribution of the lesion is more localized and not generalized in this case. So if good, you don't have those of the ulcer. Yeah. Then middle part, you're correct there. Okay. You got hemorrhage, you get enteritis, but the word ulcer there, sometimes maybe if you talk about mark, maybe reduce bit mark on that, because but it's actually nothing wrong, because when you look there, you cannot really see. But normally, I mentioned to you, the appearance of ulcer is not as general that we have there. Okay. So then agent cause or lesion is enter the host, and then they will go in the, okay, they go to PA patches, correct. They can go the tonsil, correct. PA patches is correct. Then release from lymph node, infect lymphocyte, lymph node, and lymphoid tissue. Cause dissemination, virus, viremia, correct. Or virus will infect, replicate, creep, you're correct. And cause destruction cell after replication, okay, correct. As virus particles keep on replicating, damage or epithelial, instead keep become more severe, ultimate result mucosa erosion and ulceration possible. From here, content of blood ooze out. Yeah. You're thinking ulceration, they hit the blood vessel, eh? Represented by the content of the infected intestine. Probably this is acceptable, but very good also in this case, because they ask about pathogenesis, isn't it, son? What is the question here? The second one, pathogenesis, isn't it? The fourth one, cause of death.
Yes,
You're
Prof.
caught there. You're caught there because you stop until, I don't know. Oh, you got some more here down. Oh, sorry, they're very long. I'm so sorry. You have more here. Okay. Be careful if you exam, then it's very long, whether you got enough time or not. Yeah. Venous atrophy, thinning, distraction, cell ultimate result, ulceration, hemorrhage intestine, blood ulcer, repeated content infected intestine, reduced function, small intestine, hemorrhage mucosa, bloody diarrhea, affected liver. Resultant mucosalia exposed small intestine secondary, yes, correct. There's many times also, some people believe that the hemorrhage also, apart from the major blood vessel, become more severe when the secondary bacterial infection. Probably if you say secondary bacterial infection, you have to mention what bacteria there. You're not confused, just put E. coli there, you're never wrong. Then can lead to septicemia, dilatation blood vessel, intestine, reduced venous return, poor cardiac output, poor supply vital organ, leading to ischemic necrosis of vital organ. Yes, you are right, but please mention what is a vital organ. Okay? I mean, in this case, you are referring to the brain, central nervous system, as well as the, what I call it, vital organ. I mean, it's a cardiovascular center and respiratory center. But you have to explain this one, the vital organ, yeah? You are right, but maybe the whole thing, you have very good explanation, but because of this vital organ, maybe you might not get a full mark. Maybe you might only got maybe, what I call it, 9.6, 9.7, just because you might be asked what is a vital organ, yeah? Because this part is important, because this is where actually the last point where they cause kill of the death of the animals, okay? Then the last one will be death likely to vital organ failure. You have here actually, but this one some ignorance kan. That masuk, remember ya, you have to be got details. I mean, you understand the concept. Kita tak boleh shortcut. You have to explain it, yeah. Because you have here, you can see vital organ, a necrosis of vital organ there. You got cardiovascular, you're correct. Due to ischemic necrosis, you are right. Due to septicemia, you can correct. Actually, this septicemia, you can, of course, you jump here because normally the agent will be the final one, yeah. Because you say septicemia due to secondary bacterial infection is correct actually. Follow ulceration mucosa small intestine, ulcer layer small intestine, okay. Replication of creep because severe disruption of creep lining mucosa, infected creep levercum, dissemination of virus. After replication lymphocyte, the virus infecting, P patcher release. Okay. What is missing there? Huh? What is missing you have there? First, you have septicemia. Of course, this septicemia can be as a result of secondary bacterial infection as well as fibrous infection. But you miss how this septicemia could lead to ischemic necrosis of the vital organ. Tak ada kan? You have not there. You understand? The rest you have. The image of the clip ada semua. Tapi when it comes to how this septicemia leading to ischemic necrosis of vital organ, you don't have. Because what is missing here, when you have ischemic necrosis of vital organ, actually is low oxygenated blood, isn't it, supplied to this vital organ? Why low oxygenated blood? Because of low cardiac output. Why low cardiac output? Because of low venous return. Why low venous return? You may say it because of septicemia, or why venous return? Actually low because of dilatation of blood vessel, pulling of all blood in a peripheral blood circulation due to septicemia. So you miss that part, okay? Because please remember, I mean the most principle when you talk about failure, from the lesion to failure, what you have there, the first is the lesion. Okay, in this lesion, what you have probably is a ulceration and hemorrhage. Or plus the secondary basal, you have septicemia, its condition. So it's up to you when you have ulceration and hemorrhage, whether you want to use a route of hemorrhages lead to death, or you want to use of ulceration and hemorrhage leading to secondary vital infection leads to death. Okay. If you want to use ulceration, okay, and hemorrhage lead to death, hemorrhage will always cause low blood volume, isn't it? So there will be low venous return. Low venous return with low cardiac output, low oxygen. Low oxygen will lead to ischemic necrosis of the vital organ. I mean the brain, because central nervous system as well as the cardiovascular system, leading to failure. That one you're talking about what you call it hemorrhage. But you want to choose the ulceration, hemorrhage, and the secondary vital infection, animal with septicemia. You can use also because the septicemia again can lead to dilatation of blood vessel. Okay, because when dilatation of blood vessel, of course, when you read in the book, septicemia first cause constriction. The constriction is more of a compensatory mechanism. They constrict first. But after that, they fail, that will cause dilatation. So when there's a lot of dilatation of blood vessel, so again, the blood flow back into the heart, which is called venous return, is low. Low venous return, low cardiac output, low oxygenated blood supply to the brain and respiratory center, as well as what we call cellular center, leading to ischemic necrosis of this organ. Class, can you follow me?
Yes, Prof.
Prof.
Ya, dia kena ada few step tu. The first step is how the agent enter the host, they form a lesion. After they form a lesion, how that lesion can kill the animal. The lesion kill tu senang aja sebenarnya. We just follow one route. Of course, there's so many more pathway, but we use this pathway. Okay, which is very straightforward. Kalau you hemorrhage, again they always cause a what we call poor venous return, and then a low venous return, low cardiac output. So that is a pathogenesis. The agent enter the host, cause formation of lesion, and when they form a lesion, they lead to disturbances of normal function of the organ, and as a result of that, most importantly, low venous return, low cardiac output, ischemic necrosis of the brain center, respiratory center, as well as cardiovascular center, that lead to failure of the system and death to the animals. So the flow. Tapi bila cause of death, dia terbalik lah. There will be failure of the what you call it, central nervous system, cardiovascular system, and respiratory center due to the ischemic necrosis of the organ, due to low oxygenated blood or low oxygenated blood or low cardiac output, due to low venous return, due to kalau septicemia, pooling of blood in the peripheral blood system, due to the dilatation of blood vessel, due to septicemia. Kalau you thought due to the hemorrhage, due to low venous return, due to the excessive blood loss from the body, due to rupture of blood vessel. Hemorrhage kan? Kalau you think if you due to the dehydration, low venous return, okay, due to what we call it low blood volume, due to excessive loss of fluid from the blood, due to the severe diarrhea. Tapi kalau you choose anemia, that's slightly different. Because anemia, of course, anemia also might play some role on the blood volume, but anemia itself can lead to low oxygenated blood supplied to the vital organ. Sebab blood is so important with regard of carry of oxygen. Am I confuse you? Or make more clear?
More clear, Prof.
Clear ya? Ada soalan lain? Any other question?
Prof, there's another question in the chat box.
Mana? Oh, sana. Apa question dia? Can you read for me?
Oh, okay. Lo, do you mind or do you want to read?
You can read for me, no problem.
Oh, okay. Lo asked, this is from Lo, how to make the list of differential diagnosis. For example, copper poisoning in the animal, dark red urine can be observed along with liver necrosis. So can I include hematuria in my differential diagnosis, or I must make my differential diagnosis based on these two clinical signs?
Okay. Please remember, differential diagnosis is a disease. You understand that? So meaning that you cannot put hematuria as differential diagnosis. Tak boleh. Sebab differential diagnosis is a disease. Dia bukan condition. Jadinya kalau you think that is hematuria, dia ada dua tau. Hematuria dengan hemoglobinuria. Nanti bila sampai urinary system ya. Hematuria ni is a blood in the urine. Hemoglobinuria ni is a hemoglobin in the urine. All color is black or blood. Tapi the color kalau hematuria biasanya colornya more brighter ya. When compare with hemoglobinuria. Jadi dua two different term tu. And in term of cause also, hematuria usually is as a result of damages ataupun injury of the lower urinary tract. For example, injury of urinary bladder because presence of stone or any traumatic injury. So that lead to hematuria. Hematuria maksud dia frank blood in the urine. Tapi hemoglobinuria ni dia involve with damages of blood in the circulation atas lagi. So what we have the hemoglobin, not a frank blood. So we will come later on and to answer you, both of the thing is condition. Jadi dia you cannot put it as differential diagnosis because differential diagnosis is a disease. Okay, bukannya itu. Contohnya kalau you see is a hematuria, your differential diagnosis maybe is a later on you have call it urolithiasis ataupun calculi, ya. Itu dia tu your differential diagnosis calculi bukannya hematuria, is calculi. Kalau you get hemoglobinuria, for example, your differential diagnosis is babesiosis, for example, or coccidiosis, or babesiosis, or copper poisoning, something that lead to lysis or RBC. That is your differential diagnosis. Okay, I repeat again, a differential diagnosis is a disease. Boleh? Boleh ke? Siapa tanya tadi? Jangan malu-malu lah. Are you shy? And is it okay? Is it clear, class?
I'm sorry, doctor. Just now my connection is not that good. Can you repeat again? Because I missed quite a little important part.
Okay. Yeah, I mean, what I'm trying to say is that when you say it's a differential diagnosis Differential diagnosis is a disease. You know disease? Copper poisoning is a disease.
Yeah.
Babesiosis is a disease. Yeah. Tapi we call hemoglobinuria is a condition. It's not a disease. And thus we know that hemoglobinuria actually is a presence of hemoglobin in the urine. But when you think about hematuria is presence of blood in the urine. And normally hematuria, this one is caused by damages of the lower urinary tract, especially the urinary bladder. Whether by trauma, tumor, or anything, they can cause hemorrhage. So we can see that as a frank blood. Eh? So when you have hematuria, it's a condition, but your differential diagnosis will be maybe renal calculi. And that's your differential diagnosis. Or maybe neoplasia of the urinary bladder. That's your differential diagnosis. Not the hematuria. Okay? Can you follow me?
Yeah, I can follow. So it's not important to include my differential. If I include my differential diagnosis without any relation with the liver, is it okay? Because the important sign is still about the liver.
I can get you what you're trying to say. Sorry. Oh yeah. When you're thinking about, yes, you're talking about a differential diagnosis is not something they're not related with the liver.
Yes.
I think what we need actually something to do with liver, because you're looking at liver. How come your diagnosis is heart, for example? No. You need to do something with the liver, because in this case, it's very general, something different. Because in your case, you are talking about hemoglobinuria. So in cases of what I call it jaundice, you don't expect hematuria, no. But you expect to see hemoglobinuria. There's two different things, two different terms. You get me? So
yes,
your answer must be liver, not other organ. But the only thing is that because in this case, we are talking about hepatic diseases, but jaundice can cause by pre-hepatic, hepatic, and post-hepatic. The lesion we mentioned about hematuria, or the lesion about hemoglobinuria, is more of pre-hepatic jaundice. Okay, but they are associated also with liver because failure of the failure of liver also because of this aromatic crisis. Okay, so it must be related to the liver. Okay.
Okay, thank you, Prof.
Welcome. Okay. Any other question?
Prof, I have a question.
Yeah, please. I'm happy to give some clarification.
Okay, Prof, I think can we go back to Wanzin's document, Wanzin Pinjame, because she has the picture, the first document.
Sekejap ya. Okay.
For question 3, Prof.
Question 3. Okay.
Question 3, Prof.
Yeah, describe the mechanism of lesion development. Yep.
No, I meant the third question, the third case.
Oh, the third case. Okay.
Yes.
This one. Okay.
That one, Prof. I just wanted to confirm because I searched it up. Like the differential diagnosis for this, it could either be hot cholera or salmonellosis, can?
Yes.
So I did, like, I searched it up, and then they say like you can only see the lesions when it's chronic. So I got kind of confused whether this is actually acute or chronic.
And in this case, the lesion is a chronic because you can see ulcer there. You can see the surrounding with the number of fibrous tissue also. Well, it's not acute, but you can choose as a subacute or chronic. Okay. Can you follow me? It's not acute.
Oh, okay. Thank you, Prof. Lepas tu kan, Prof. So,
sorry.
Oh, tak apa, continue, Prof.
Yeah, I mean, when you look at this lesion, definitely they are not acute. You can foresee that there will like ulcer there, but the surrounding of tissue there, surrounding, the tissue response takes some time. Even the serosal also, we can see there's some tension on the hemorrhage there and surrounding with tissue. So this type of lesion can be subacute or chronic. So you can choose either subacute or chronic depending on the times. Both is right, but I would prefer more of subacute rather than chronic. Okay? It's our choice. It can be subacute, it can be subacute or can be chronic, but not acute. Okay?
Oh, okay. Thank you, Prof. So, Prof, I just wanted to confirm, like, one of the questions asked, like, the final diagnosis. So, is it hot cholera or salmonellosis based on the picture?
I mentioned earlier, most of the time for this, when you have a real case, we're going to have both, what you call it, hot cholera or swine fever virus or salmonella. But we can put, I think, looking at that button ulcer is always more towards of swine fever. Okay? Swine fever.
Okay.
This correct here. Most likely, name almost likely is a swine fever, correct? But you say salmonellosis, so it's not wrong. Because I'm not sure until now whether there's a lot of certainty whether, because most of the time when we have swine fever, they have salmonellosis, both are there. But I might do some research now whether they have solved this issue. But if you give either, it's always right. Okay. Can you hear me?
Yes, thank you so much, Prof.
Ada soalan lain? Now you're most welcome to ask, because I'm happy to listen your question. Because when you start to ask question means you're active. Critical thinking, sir. You start to think what they are. And I wish that I can assist you to clarify whatever doubt or whatever confirmation you need to have.
Prof,
Yes, saya.
yang case nombor 3 ni, yang first question describe the lesion tu, how to describe the lesion?
Oh, describe the lesion. Tengok kat sini contoh dia. Okay. They mentioned the presence of fibrin and button ulcer on the mucous intestine indicate of fibrin effusion from the blood into the lumen and ulceration. Multifocal hemorrhage on the serosa or the small intestine. Edematous of small intestine indicate of enteritis. Okay. Yang ini itulah tadi, kalau kita lihat kat situ, those of the description is quite acceptable, because although I mentioned just now, kita dah pakai word of lesion, but sometimes very difficult for us to avoid this use word of ulcer. Yeah. So you have fibrin and button ulcer, yeah, acceptable. Mucosa intestine. Why it may subacute, although they are present because of the localization there. Yeah. Cuma yang put them multiple hemorrhage on the serosa or the intestine. Yes, I think that reddening, although it look more like congestion, but it's actually hemorrhage. They are different, yeah. Between hemorrhage and congestion. Congestion normally generalized. But in this case, because that hemorrhage actually in the ulcer. Tapi yang darken ni is not really fibrin actually. This darken actually is a blood, yeah, because of that hemorrhage. Yeah, it's a blood ulcer with a blood appearance there. Okay. Cuma when you put edematous small intestine indicate enteritis, yang ini tak berapa tepat lah, yeah. Because remember that enteritis is something to do with reddening, mean the hemorrhage will play important role on the enteritis. Fibrin also is something to do with enteritis. Normally in cases of edematous, although edematous so may lead to inflammation, but sometimes edematous condition might not need inflammatory responses. Contohnya in cases of any edema. Edema is only imbalance of blood osmotic pressure, blood tissue pressure, and tissue osmotic pressure, and what I call it tissue blood pressure. they don't need an inflammatory responder. Jadi yang sini kurang tepat. Kalau you thought about the indication enteritis is mainly because of the hemorrhage. They got also you talk about fibrin there. This you might also present an ulcer. So this one that is a solution for enteritis, not the edematous, ya. Okay. Susah kan? This susah. Sorry.
Thank you, Prof.
Okay, boleh ya? Okay. You faham kan? You faham yang because edema ni they do in edematous. Of course, edema can be a result of inflammation. Tapi if without inflammation pun edema can occur. Yeah, of course edema is one of the one of the sign of inflammation. Cuma tanpa edema pun inflammation could occur. Tapi kalau hemorrhage and then what I call it fibrin particularly and the ulceration, they also memang more focus on enteritis lah. Not completely wrong, but we can accept also. But there's some argument there. Eh? Okay, thank you. Any more question?
Less, Prof.
Sorry?
Yang question tu, yang discard deletion tu.
Yang mana?
Yang discussion discard deletion yang nombor 3.
Which question?
Case 3.
Case 3.
Yang tadi tu.
Question 3, okay.
Kan discard deletion tu. Dekat gambar lesion tu kan masih ada yellowish. Should we mention the yellowish on the...
Oh, yang yellowish ni?
Yes.
Yeah, you want to describe, you can. You want to the color, can, no problem. Boleh?
Okay.
Boleh, yeah. Because anything that is being there, you can always describe, no problem. The color, no problem. This is very subjective, yeah. Boleh. Class, anything else? Okay.
No problem.
Kalau tak ada anything else, I'm most welcome. No worry, I'm available. Okay, kalau tak ada, I mentioned earlier, if you think that you need another revision or able to clarify, of course, you can always arrange. You can have the time for that. Otherwise, I wish you all the best. And once again, take care. Take care of the COVID pandemics. Because now it seems that the virus is almost everywhere. And I mentioned on Monday also, there is chances of course, those of the infected, they are infected, but there are also direct contacts. So if direct contact we need to do a swabs, but there also a close contact. Yeah. So all need to do what we call it self-quarantine. Yeah. But most of the important one, if possible, to reduce the number of contact or meeting people at this time. Yeah, because we worried also. Although you are still very young, in principle you are quite okay. Okay, but prevention is better than cure. So please take care, and see you again. Maybe when we may have an oral examination. So when we will see you again during the oral examination. Because of course your test will see, but maybe test might not able to communicate directly. But if you got any question, you can always ask. And once again, if you need to have another class, so we may arrange for that purpose. Okay, thank you very much. And I wish you all the best and take care. Okay?
Thank you so much, Prof.
Okay, bye. Yeah.
Thank you so much, Prof.
Thank you, Prof.
Thank you, Prof.